Thank you everyone for joining us today, and welcome to what I believe is the fourth Safety for All webinar of 2024. I'm delighted to be joined today by Matt Phillips, the Chief Nursing Information Officer at the Royal National Orthopaedic Hospital NHS Trust, and Helen Moore, the Director of Planning, Performance and Informatics at the South Eastern Health and Social Care Trust. And today they'll be presenting our Safety for All webinar on enhancing clinical communications at South Eastern Trust and the Royal National Orthopaedic Hospital. So without further ado, I'll hand over to Matt. So Helen and Matt, thank you so much for your time today.
Hi. So the first thing I was actually going to talk about was on a different slide, actually, Josh. It was the pulse one. So while the slide's coming up, I'll just sort of give a brief overview. So we had a there you go, a issue within the trust. So the Royal National Orthopaedic Trust, for those who don't know, is a primarily elective hospital who specialises in orthopaedics and MSK work, and we have 14 theatres for a relatively small bed base of 180 beds. And we have lots of children that come through our theatres. And as anybody will know on the call that's ever recovered a child from an anaesthetic, it can be quite a risky time. And having the parents there is always great benefit to not only the child, but the members of staff and the parents obviously as well. So we kicked off with a project some time ago now, and it was mainly Sam Higgins, the recovery sister, and Noreen, who was from our QI team, to give them the credit for that. Next slide, please. So our mobile reception within the trust is, to say sketchy would give it would be inaccurate. It is non-existent in most of the trusts. So we had problems when we had a child coming in through theatre, is giving patients an accurate, or patient's relative, as in the parents or the carers, an accurate time when they'll be coming through to recovery, and trying to get hold of them once the patient is coming off the table and into recovery. So we wanted to use a system where we could give them a device, so they could go away from theatres, they could walk around the trust, they could go and get something to eat, they can go and sit by the lake. We have a nice lake in the on the premises here. So and then we could be able to get hold of the parents to say, maybe with an update, maybe to say there's a delay, or to say, well, they're going to be coming through to recovery in 10 minutes. Can you please make your way back? Because having the parents there seemed such a benefit from having from recovering this child. So we went to our communication solution people that we use Vocera within the trust, and we ran the trial for several months in collaboration with the Striker Vocera guys, and we came up with this idea of a patient pulse. So it was a badge, and I'm sure you saw in the first slide, which was a small badge, and we named them all in animal names. And they would carry these badges, and they would go and do whatever they wanted around the trust, and the person in recovery would use their Vocera badge or via the phone, and they would be able to get hold of the relatives whenever they wanted. Sometimes it was just to give them a bit of an update, and other times was to say they're ready. We did a little bit of work beforehand. Next slide, please. So we I've sort of covered this, haven't I? So we that's it. So we did a questionnaire to the parents and asked them if they would think it was helpful, and over 90% would say they would welcome some initiative like this, because they, and to quote them, are petrified, worried that she wakes up without one of us being there, anxious, upset, stressed, sick, was all the words that we were getting from this quick survey. Next slide, please. So to help reducing this anxiety, and also we had some other perceived benefits as well. The patients' relatives were often going back to the ward And then one of the nurses from the ward was often bringing the patient's relatives back to theatre. So by having this badge, we were able to reduce the amount of times that nurses were spent escorting the parents around from recovery and to recovery. We wanted to reunite the child with their parents as early as possible to aid the recovery. This also had the knock-on effect of actually reducing the amount of time that the patients were in recovery, because obviously, you know, if we can get them out of recovery and back into the ward, it benefits the patient, it benefits patient flow through our theatres. Next slide, please. So we did the initial questionnaire. We then contacted the Stryker Vocera team after we actually did a bit of a search around other devices that were potentially available, or anyone else who had done this. We didn't find anything from a literature search of any other such initiative, certainly within the UK. We then discussed with various other people, obviously the theatre manager, recovery manager, the paediatric surgeons, anaesthetists got involved, and I got involved, and some of the other QI team, and Noreen was the one who led it from our QI perspective. Next slide, please. So we also had some volunteers involved. So we're very much into co-collaboration here with ex-patients, and we've got quite a good volunteer group, and they also got involved and were the trial, if you like. We used them as the guinea pigs to see if this would work before we gave it out to any patients' relatives at the start. Next slide, please. We also had some challenges, as we do with any new innovation. So it was very clear that this is a very unusual site that was primarily built in the 1930s and has been added on and added on. So we had to, because the patients relatives weren't going to be escorted, we had to devise maps and some directions. The device, the Vocera device, hadn't been used for this sort of communication before, so we had some idea of how the configuration would go, and together with the Stryker Vocera team, we refined that over several weeks once we went live to get it working perfectly for the purpose we needed it. We also needed to do some staff education around the time, and once we went live initially, we realized that actually we hadn't done our full due diligence with the paediatric teams on the ward, and we had to go back and retrospectively do that bit of education. There was a couple of difficulties initially with the patient pulse with the Vocera device, because we hadn't disabled a function to allow them to speak, to call, which we needed to do, and in addition, several other users of the Vocera network within the trust accidentally got through to patients' relatives on a couple of occasions. So we had to do some tweaks a couple of weeks into the trial to make sure that that didn't happen. But it was a learning process, and we went through that period. Okay, next slide, please. Okay, so the questionnaire was given out after each use, and actually over 93%, which I'm sure everyone will agree is a very high figure, of people welcomed advice. And things that were a very common theme throughout was it was comforting to know that they could be contacted, that they could go anywhere they wanted, and they didn't have to bother by phoning up. We used to get quite a few phone calls into recovery to say, what's happening with my child, what's happening, do we know times? But because they had this device and were getting updates, and they had the reassurance of having this, it reduced the amount of calls coming in. And that was reported from the paediatric ward as well, because they would often field some of those calls. Next slide, please. So of the feedback, 20 out of 24 recovery staff felt that it had been useful. It was easier to get hold of parents. There was help delay times and between 15 and 30 minutes, so it's quite a substantial amount of time. We did have a couple of problems and they're highlighted there, but I'm not going to go through those again. Next slide, please. So 94 out of 100 patients said they felt confident leaving to be able to go for a walk, which was really good. We found that we had some problems with navigating their way back to recovery areas. So we've since done a load of signposting and improved our signage. And that came out of this project. So next slide, please. Okay, so the trial period actually did finish on the 3rd of June, or just afterwards. We've since collated all the questionnaires in. We've got anecdotal evidence from the ward staff and some theatre timings as well to aid the business case. So we're presently just working on a business case to put this forward as a permanent solution within the trust. And we're also going to extend it out beyond the grounds of the paediatric patients. So we're also looking at some of the adult patients, especially those coming through with learning difficulties or with carers. So we'll be doing that over the next couple of weeks. We'll be formulating the business case for that. And that's the end of my presentation. Over to Helen.
Thanks, Matt. I'll just start while Josh is putting up the slides, and I'm absolutely delighted and honoured to be representing the South Eastern Trust in Northern Ireland. I am Helen Moore, the Director of Planning, Performance and Informatics, and I'm very proud of the fact that I am a registered nurse and still from time to time end up in a set of scrubs working in the hospital setting, in the acute setting, which is my home from home. I have a colleague on the line today, Stephen Powell, and it is testament to his team and those of the clinical and operational services that I'm even able to talk about improving patient safety through effective clinical communications. In the South Eastern Trust, if you move to the next slide, I'm just going to give you a little bit of a resume of who that is in Northern Ireland. And if you just press again, there'll be a second slide come up with some facts and figures. Thank you. Basically, in South Eastern Trust, we are an integrated health and social care service in Northern Ireland. So the Trust provides both community and hospital provision of services right across the entire population. We're on the outskirts of Belfast, but we run right down into very rural areas of very low density of population per square mile. Between bank and substantive staff, we have nearly 16,500 staff, and our budget would be exceeding £1 billion now. And we are also providing regional services for Northern Ireland's population, which is about 2 million people. And those are plastics and oral maxillofacial surgery. And also we are proudly the providers of healthcare in all of the prisons in Northern Ireland, right throughout the entirety of Northern Ireland. And that brings a unique set of challenges. We have one networked model, one large acute hospital, which was on the previous picture, which has been undergoing significant investment over the years for redevelopment of the site. And then a supporting hospital network with Lagan Valley Hospital and the Down Hospital are two local hospitals. And they provide a wide range of services in the local community. And common across everything is the demand that's been placed, whether it's in Northern Ireland or over in England, Scotland or Wales. There are significant demands being placed on all members of staff. Capacity is not keeping up with demand. Our waiting times are the worst in the UK. In Northern Ireland, we have 1 in 4 people on waiting lists. And yet our teams continually strive to make this a great place to work and to live and to receive care and support right throughout the entirety of the population. And one of those things that they're keen to do is that they are committed. If you just press the button again, Charlie and Josh, it will show that we are committed to delivering safe, timely care. Thank you. So one of our big things here about clinical communication is basically in South Eastern Trust, we mightn't be the biggest organisation in the UK, but we certainly work on the principle, go big or go home. And we have teams who are real visionaries, who have led the way and won many national awards for the work that they've done. And I believe firmly that why they've succeeded is that initiatives are clinically led and our digital teams enable those to happen. And very importantly, that our chief executive and the executive team and leadership teams throughout the organisation work on the principle that you can be a leader of anything if you put your mind to it. You do not have to have the status of a band or grade or title. And that we ask and implore our teams to think, how could I do my job and how could I improve my job, and then own that. And one of the big things that we have really concentrated in is patient safety first, with a quality lens applied to that. And that has been strategically aligned right through from a service level to a trust board level on the corporate plan. So much so that a couple of years ago, our trust board agreed to prioritise 3 major quality initiatives that would be trust-wide supported, enabled by all the corporate teams, whether they were finance, HR, workforce development, the quality team itself, or the planning team, or the digital team. All teams lead in and align alongside those major initiatives. And Vocera has had a part to play in all of those, which I'm now going to explain to you. And we have a very much a whole system approach. The patient does not see these invisible silos or barriers that quite often services work in. You're okay, you can move on, thank you. And that one of the things that we know is communication across those different divides can be difficult, because there's physical split. You know, you work in a hospital and yet you need to communicate to a district nurse or to an allied health professional who's supporting teams and patients on their discharge. And many errors, we have a complaints report only published in Northern Ireland today, and many of those complaints rest within the communication. Lack of it, miscommunication, late communication, you name it. 80% of major errors can attribute some element of responsibility down through the communication. And as a nurse, I'm always striving to see what can we do better. So suppose, like Matt, we have used a wireless communication tool called Vocera, and that came in 2009. So this is not new news to the South Eastern Trust. And why it came was because we had a major problem with maintaining our services in a new hospital that had been built in the local hospital. Down Hospital was opened in 2009. And there was no possibility that we were going to be able to actually provide all the care without some aids and tools to help people work with a higher complement. At that time, we had a 24-bedded ward with 2 bays of 4 patients and the remainder as single rooms. This was a complete transformation. It was like an old cottage hospital style, built in a very old stately house. And suddenly we were going to a state of the art. And from 2009, we were looking and we found the Vocera device. And I know it's successful. These metrics demonstrate that. We now have nearly 750,000 internal calls and alerts per month going through the Vocera system, which is just unimaginable when you think about how any other way you would have to do that. It has been integrated with our nurse call. We have over 2,000 devices in the buildings, and we have a number of people who have, for example, myself, have the app on their phone, so it can be used in other mechanisms. It has, how I know clinicians like it, they keep asking us for more of it. Stephen and my head is turned, trying to look after all the requests that we get of ways, innovative ways people are looking to use it. And I get the feedback that it reduces clinical time lost, waiting on phones, remembering to go back to phones, leaving the patient when you really don't want to, for example, on some occasions, trying to find locations where people are. It replaced our bleep system and made us more efficient. There's a better record of the information that we have, because there's data behind it that demonstrates if the system's working. And it has been used right across the professional boundaries. So it's not, again, professional centric. Our doctors use it, our nurses use it, our non-clinical staff use it, our admin staff use it, even our executives use it. I, for example, have it on my device and it's used for contacting me during major incident, for example. We have a very small switchboard team, and quite often in clinical, you never think, you just press switchboard. But that very, very small team are trying to facilitate managing alarms, managing the public, managing to redirect staff who are trying to find people both internally and right throughout the whole of Northern Ireland, because we work as a networked model. So we wanted to speak to a stroke specialist in the Royal, which is our neighbouring acute hospital and the Regional Centre for Stroke Services. In the past, they'd been ringing switchboard to say, could you find me the switchboard person on call? Likewise, even internally in the hospital, if it was a gynae patient in an emergency, they could have been ringing switchboard. All of that took time. That doesn't have to happen. You are in control of contacting the person yourself on your own device. And it helps, therefore, to return time to care. It also helps for information for incident management, so we can see how many people responded, etc., to a major incident request. And it's used in the protocols, which is very much a strategic direction. Next slide, please. So if you just press about 3 buttons, that should, another one, please, maybe, that's us. So the old process, being a nurse, I know something wasn't right with the patient. You wanted to get a doctor or another professional. You had to leave the patient, you had to leave them in a state that you could. Go to a phone, find the phone. And in big single rooms that we have built as part of our health building note compliance, that's a long way back to a phone quite often. And then that doctor may have been on a phone somewhere else or nowhere near a phone. So the problem with bleeps, etc., was that you were relying not on Wi-Fi, you were relying on the old telephony system and the bleep system, and it queue stacked. There was no auto escalation. Now the patient can actually work at the patient bedside. They can literally press this little button on the device and say, call doctor on call, say respiratory doctor on call. And that takes it right through to the right person. Instead of people changing, I know doctors can change their shifts. Switchboard had a horrendous time trying to keep up with who was changing into what shift. No need for that. And if the first doctor's busy, it will move on to this queue stack of doctors that have been prioritised in the rota. So the patient knows too that someone is coming. The nurse knows that it has been responded to. And it reduces that burden of stress, is someone coming to my aid, and also that reminder, that emotional burden of doing that. And that has been significant, and that is the one thing that our staff keep coming back to us about, is its usability. And they just, as I say, they can't get enough of it. And that brings with it its own challenges, both financially in terms of resourcing that, and then managing it in a very small ICT team. Next slide, please. Press again. I'm going to only touch on this because we're going to major in this in a few minutes, Matt and I together. So I'm in Northern Ireland, Matt's in England. He's a massive big regional centre. I'm in a acute hospital with some regional services. And I had never met Matt until I think it was May. And yet our teams know each other, and Matt knows some of my team. And it's amazing that both of us have landed in on the one place, which is the strength that this brings to cardiac crash calls. And a genuinely 2 minutes to 2 seconds on a call response is actually measured. That's not me just making that up as a fancy strap line. And together with the resuscitation team, and I need to give credit to Heidi, who works in our resuscitation training team, they started to look, was there something more they could do with Vocera? And you can see there how I have alerted the old process to the new process, and how you can mobilize an entire team within 2 seconds instead of the 2 minute process roughly that it took to receive the alert on the bleep. And that, in one of the most stressed moments of any nurse's day or any professional's day, is absolutely, like, I remember the old world where you're shouting up corridors for someone to ring and trying to deal with grabbing the trolley and get back to the patient and all the things you had to do. To imagine you could do it from the wall, and ours is fully integrated with our call handling, with our call system up the back of the bed head. And it's even, we're just very fortunate we have managed to build all this together by the new design of the hospital that we opened a couple of years ago, that the call button and the Vocera and the whole system all works together to bring it all together into one system. And again, that would not have happened if the clinical team hadn't have said we have a desire to try, and that there was checks and balances put around this, because this is obviously one of those areas that deals with significant scrutiny when it happens. So we know that the stakes were high, and we needed to support this significantly to make sure that what we developed would be usable. And it maintains the protocol for the 6666, which is our buttons we press when we have a cardiac arrest. We are, and I'll pick it up with Matt later, we are looking at what Matt has done about the other part, about the paediatric call and also the urgent calls for 6,000. We think there's more we could do. You can hear the teams are always pushing me hard. Next slide, please. So this slide here encompasses our EPIC system. We're very proud track history of digital innovation. And it just wasn't with Vocera, it has been with digital Wi-Fi available to the public on our sites, for example, because we, like Matt, have problems with our mobile signals. Different providers have different strengths in our area. And we, for example, had gone to a Wi-Fi enabled service for the public, because so much of the public now are able to communicate with their family at home instead of the bad old world where they used to ring the desk in the morning and ask to speak to the patient, and old payphones had to be pulled around. So Encompass is the affectionate name of the programme, which is the EPIC electronic patient care record. And it's no mistake, the South Eastern Trust have gone first with that integrated record, which was a major install right across the entire trust for the whole of Northern Ireland on the first instance. And in that, there were many safety concerns, obviously, at the time of go live. So on the night of go live, it was recognised that patients' records may not have been brought up to date in the clinical system electronically in that record that had happened since midnight, because there was a 4-hour window when nothing more could go into the electronic record, but patients still take sick and need extra medication started, like pain relief. New patients had to be admitted. And there was a window where they had to stop putting into the new system the migration of data. And at 4 o'clock in the morning, as I did the final check as the senior responsible officer for the programme, I realised there was a risk, because the doctor could have written it on the paper script at the bottom of the bed, medication script. But actually, if someone went to the electronic system and depended on it to do their medication for the 8 a.m. run or during the night, they might miss something or give something that they shouldn't give. So we did a mass call to highlight that they needed to check the manual and the electronic and check for any changes. And I didn't have to rely on word of mouth. And certainly in the middle of the night, nurses aren't sitting and clinicians aren't sitting looking at their emails. And if they are, it's ad hoc, and they've many things to cover. And that allowed me to know that all people working a shift had got the mass announcement that they needed to check that pharmaceutical, and that ticked the safety box for me. The second thing was, because we are transfer across entire system, we were concerned that we had one focal point for the actual go live announcement, which has to be physically somewhere, and I couldn't be in 3 places at once, nor could my chief executive or the programme team. So we had to think of a way we could actually tell everyone we are now live in this system. And that was also done by a go live announcement on the broadcast function that Vocera carries. So if you were on shift, you got the message on the system. And a lot of people said that they felt part of it, even though they might have been 40 miles away in a different location. And that, again, really meant something to my chief executive, who is also a paediatric nurse, myself, because nothing is delivered without a team. Calls between clinical staff at the time increased and have continued to be elevated at 15%. So that's, I want to check in with someone. How do I do something? You can speak to them just like a phone, but you don't have to go and get them to a phone. You can get them on their body with the Vocera. In addition, we had super users and experts, and they were all armed with a badge. And we had hubs that supported people in key locations throughout the trust. And from that hub, they could redirect a super user to an area that was struggling. For example, if they were having problems sorting out a blood transfusion order, really important and time focused, we could redirect that super user without having to get them to come back to the hub or trying to get them on a phone line. In a big site, that's really important. And they also could work across sites on the Vocera to test things. So could the professional teams. It reassured the staff. It supported that transition through critical periods during the night when there's less people about. And it really did help both in clinical comms and in operational comms at the time to improve the experience of the whole thing at go live. And just from the 6th of November was the week we started to go live, and then the 9th at 4 o'clock in the morning is when we went live. And between the 6th of November and the 20th of November alone, we nearly hit 500,000 sessions in the 2-week period. I cannot begin to imagine how I would have coordinated the movement that was the go live without that. And it's part of our DHC, which is our Digital Health and Care Northern Ireland strategy, that there is a commitment there that digital solutions will put quality and safety first. And I've seen how bringing it in innocently in 2009 has grown, and how actually digital used well and exploited to its maximum capacity can actually help clinical and operational staff work together. And whether that's bring a cleaner to a situation where you need to prepare a room urgently, you can call them through using this system, right through to I need a doctor now, I have a mass blood transfusion issue, or we have a cardiac arrest issue. So this is really significant for me. Next slide. So I said, we keep getting pushed hard. So this long list of bullet points, and I'm not going through them, indicate the scale of how this is helping. So I'm going to just pick out, for example, stroke. Stroke's an amazing pathway. We have a Dr. Mark Bowman who drove its success. And in that, he looked at the whole lysis pathway. And to explain this, if you haven't got it yet, this will give it to you. We had a 16-year-old on their way in an ambulance, potentially needing lysis. The call went out on the pager, or would have went out on the pager. Vocera also put it out. And in the past, you'd have just put it out in the pager and you wouldn't have had a clue if anybody was going to be standing with you in ED when the ambulance rolled into town. The broadcast call went out, but importantly, they were able to personalise it. So they said possible lysis in estimated time of arrival, etc. But what they did was they alerted that this was a really unusual case. And the person responds to say, on our way. But actually what happened was you can see real time who's responding, so you know the team's coming. But what they were able to do was they were able to see the significance of this particular case. Every case is important, but a 16-year-old is highly exceptional. And rather than leaving it to one doctor and maybe one lysis nurse to deal with that situation, key strategic people came alongside that core team to ensure that that child, young adult, got the best possible output. There was no patient identifiable information provided. I am the Chief Information Responsible Owner, all linked to information governance. I am content the system works. And we were able, and all were standing on standby in ED, a strong team ready to receive that patient. And that concludes my presentation. And Matt and I are now going to talk about my favourite one, the cardiac arrest.
I'll just take myself off mute. So yeah, I mean, as Helen said, we the crash and medical part of implementing or decommissioning a bleep is often the most gives the most anxiety to the rest of the trust. And we actually went bleep free and went completely over to Vocera on the 1st of April 2020, which, as many of you remember, was quite a busy time because we were just sort of hit, the start of the pandemic was just sort of hitting at that time. But we went live with our crash and medicals on Vocera several months before the actual full go live, and we used that as the benchmark for the system working and to reduce the anxiety over the whole bleep decommissioning entirely, because we was able to successfully demonstrate the benefits of having the crash and medicals onto the Vocera. Can we go to the next slide, please? So we have, primarily for a clinical safety point of view, we have 3 emergency teams. We have a medical emergency team, paediatric cardiac arrest, and adult cardiac arrest teams. And the old problem, the old system of using the bleeps, just as Helen had said earlier, was the bleep goes out. You have no idea who's received that bleep and if they're going to turn up or not. You don't know if the bleep's working, where the person that your response team is. You don't know if the batteries run out. You don't know. You just don't know. So as somebody who has spent most of my career running around hospitals of various shapes and sizes on cardiac arrest and trauma calls, etc. over my career. It was frustrating when you turn up when you've got the bleep and you don't know if you've got an anaesthetist, or you don't know if you've got this other essential part of the team. Next slide, please. With this system, the call will go out, so there'll be an emergency, so it's a different tone. It will say that there's an emergency in such and such a place. It's an adult cardiac arrest call, for say, and it will ask you then to say your role. So and it will give you examples of that. So if you're the crash nurse from ITU, or if you're the RMO or the ITU registrar, you don't have to press the device. You just say ITU registrar, and that is then on the system in Switchboard. It is ticked off to say that you've responded. 1 minute after the call goes out, Switchboard then contact the lead for the cardiac arrest team, again via an automated system, to say ITU registrar hasn't responded, or anaesthetist hasn't responded. Or so if I was running the cardiac arrest team that day, which is part of the critical care outreach, or what we call acute intervention team's role, I would know that, right, the anaesthetist hasn't responded. I need to worry about the airway. I need to put someone else on that. Whereas if I didn't know, you would assume that they were coming, or hoping they were coming within the next few minutes. It also works really, really well with analytics. How many times have we had to investigate a cardiac arrest call going out and someone hasn't turned up, and then they say they haven't received it, or there has been people that have turned up late, or we've now got full analytics on this, so we can look every day back at the calls that's come in over the last 24 hours, see who responded. We can even see where they were, where they responded. Even if they didn't respond to say their name, we could tell if the badge had received the call or not. And if the badge doesn't receive the call because it is in one of the very few black spots of the Wi-Fi, which is pretty much only between levels 3 and 4 in one lift shaft, it will keep trying to send it. So as soon as that the staff member comes into a area where they do have reception, they will receive the call. Which is great, because the old bleep system didn't do that. It sent it out once. If it didn't receive it, it wouldn't keep trying. So the analytics part of this has been brilliant. Helen has been fortunate enough to link it up to the call bell systems behind the bed. We've presently got about 4 different systems in the trust from behind the bed calls, and 2 of them are not really digital, so we haven't been able to do that yet, but it's certainly on our roadmap for integrating that and to lessen that time of the response. But at the moment, we are using the cardiac arrest calls going out on the Vocera. We've got the analytics, but we're still using the 222 system, which we use, not 6666, for generating that call. Next slide, please. As I've already said, that the real major advantage is that you can know instantly the person who's leading that cardiac arrest or medical team is alerted straight away if people haven't received the calls, and it keeps trying to send it, as I said. The other advantage, of course, is that on the bigger Vocera badges, it has all the details on there as well. So if you were in a really noisy environment when the call came in and there was 2 ward names that sounded familiar, or there was a little bit of additional information like main gate to the left of the chair outside, or whatever the additional information was, you could look on the badge and you can have it, and it is written there to be able to direct you to where you're needed. But I think from a system overall, I mean, Helen mentioned it as well, by using the Vocera system instead of the bleeps, we've got so many benefits which we found really hard to sort of put a value to. But I think the biggest one is how many hours of my nursing career to date has been stood by a phone, stood by a phone, bleeping somebody, putting that down, and then 30 seconds later the phone rings and it's a relative asking about their relative, or you know, someone else on the phone, and then you've got to then either ask them to leave that call, or you need to go and bleep from another one, or you wait there for 5 minutes and the bleep's never been received. With this system, you don't have that problem, because if you don't get through to the person you need to get through, it gets put through on a call flow system, which is all configurable to the individual trusts.
I think that's a really important point,
yeah.
Matt. And one thing I would stress is it's a hidden win. A lot of our junior doctors obviously rotate across Northern Ireland, and they have been very vocal in their concern if they come from us to us from university and we're their first placement, when they suddenly discover that the next location they're going to has not as much digital enablement of communication. They are seriously concerned. They don't know how they're going to ever work in a bleep system. And that's been interesting, because our chief executive meets every single consultant to be that comes for interview, and she meets them way before the interview process, every single candidate, and or she offers them the opportunity. And one of the things that's cited is the digital enablement of better practice. So that's just one group of people who have been sense checked about the importance of this. And obviously cardiac arrest is one of the examples of that, but they just say for daily practice. And we see that as helping to attract and retain staff, because it just, as you say, removes the stress of it. For example, this winter, we were looking at how in any improvement journey, you're looking at how can I improve and reduce minutes wasted, and to maximise the safety of the journey that a patient goes through, and for staff and their stress. And one of the things we did was we reset how our ambulatory hubs, so we have a number of ambulatory hubs that support the unscheduled journey. So we were noticing quite a few people coming with urology problems, and we needed a urology opinion. And we, because they may not need admitted at all, if we could actually do something and back out. And rather than rely on, you know, we would have used that if it was urology to go to theatre, for example, in the past, if it had been torsion of testes and it was urgent and had to get there. But actually, this was a new way of working. So it's actually the urology ambulatory hub lead now carries the Vocera title for that. So they don't need to know what doctor's currently working in the ambulatory hub. They just need to know, contact the lead. That could be a nurse or a doctor, and they will sort out the issue that ED needs to deal with to try to avoid an attendance sitting for hours, because obviously higher acuity patients will be taken ahead of someone lower, but they're still really important in how to help smooth the flow and overcrowding. So those are examples of how our teams are constantly checking, changing and working. And maternity are rebooting their programme. They've had a lot of people change in that team, and they're looking to see what more can they do to benefit from the communications in a high acuity atmosphere, high risk, high stakes with babies and mummies, to be how they can use it to respond more quickly and seamlessly, and have a really good audit trail, Matt, of where weak points are in their system to respond to. Yeah. Some of the hiddens are hard to get as an evidence base, but they're there. Mm-hmm.
Yeah, that's what we found really how when we were going back to the executive 6 months into the deployment is, and people very, very quickly forget about the time spent by the phone, don't they? And having to look up numbers for bleeps and et cetera. And as you said earlier in your talk, you know, if a nurse on the wards or a physio or an HP or anybody needs to get hold of a particular team, they no longer have to look for the bleeps or which consultant are they admitted under. They literally say, can I speak to the spinal team, spinal SHO, and it just puts through to whoever's on spinal that day. And if the spinal SHO goes off for teaching and someone's covering, they just add themselves to that group, and then they can be, and then it goes straight through to them. Mm-hmm. And the system, once you've done a bit of training, the system works incredibly efficiently. And I would love to be able to have stats on the improvement, but unfortunately they're just one of those things it's almost impossible to get.
Mm-hmm. We have a really good quality improvement and innovation lens, and even that has it's been in pockets of specific examples, but I think the very fact both organisations have delivered a cardiac arrest response using this digital system is testament to the validity of it and to its credibility and reliability. because there are many protocols around this. The Resuscitation Council of UK came and have seen this in play. They were here for major training, and actually it's really interesting. But we have like a newsletter has just come out only about half an hour before this program started. And in it, they have a picture of in the newsletter, they have a picture of the training, and it was simulation training. So obviously a team who train together work well together. And actually, I actually thought, oh, if that had been here the day ago, I'd have put that into the slide deck. The pictures of the entire team round the dummy in the bed, and every one of them have their Vocera badge on, Stephen. So, and that, so, you know, I went, oh, if I'd have had that, I would have showed it, because even in training, they use it because it's one of the vital steps in the process of actually responding to an arrest call, to understand what your part is to play with that using digital enablement. And that's why I love the job I do, because there's always new things you can innovate and do better. Yeah. Absolutely. I'm not sure if anyone has any questions, Josh.
We can't hear you, Josh.
Thank you so much for your presentations. Incredibly informative and interesting. If anyone does have questions, please pop them in the chat. All audience members are muted with their cameras off, so if you do have questions, please put them in the chat. Got a few more minutes for a quick Q&A. I've got a question here. How significant is the role of clinical comms in reducing avoidable harm and improving patient safety?
Helen, I mean, the only thing I'm going to say on this is I have spent a lifetime as in a career with the NHS investigating incidents, and I can assure you that not a single one of the thousands I've investigated, there hasn't been a communication element to it. And the more you do to improve communication is always going to increase patient safety. But you may have some example, Helen.
Yeah, I think that patient safety, like I mentioned it earlier, it's the Joint Commission Centre for Transforming Healthcare released a report, and they pointed out that 80% of serious medical errors in hospital, now it's in hospital, miscommunication is behind it. So, you know, if there's always a part of it, no matter, as you said, Matt, what you go in to investigate, there'll be an element of, I misunderstood, I didn't get that in time, it wasn't recorded properly, it wasn't recorded at all, it wasn't in the right part of the record. You know, I didn't hear that, the call didn't answer. I've been the nurse who bleeped a doctor, whose doctor's bleep didn't bleep, according to them. You know, so, you know, then it becomes a very much not a team sport, but a blame sport. This thing just removes all that. There's objectivity. When you go in and look, you can see exactly what's going on. And people are under significant pressure. And anything I feel I can do as the director responsible for digital to help improve the safety of patients will help the well-being of staff, because staff don't come here to do harm. That's my view. They come to help the patient. That's what you train for. It's what you work as a team for and you show up to do. Clinical communication tools, for example, this thing came into its own during COVID. Because Matt, I'm sure, like, there's things we forgot to even say. I know this works under all the PPE. It can be sorted out and cleaned, but it can work under the PPE, no problem at all. When we were in rooms and the patient wasn't well and the nurse, you maybe would have said to somebody in pre-COVID life, when there wasn't all the barriers to wandering in and out of rooms, you would have maybe said, could you come and have a look? I'm not that happy with this patient. You know, sense check with another professional you trust. Well, that was a nightmare if you were trying to gown up the way you had to gown up with all the PPE and FFP masks, etc. And yet you could speak to them with the Vocera badge through the doors closed with all the gowns on, and you could have a communication, no problem whatsoever. We have also used it, for example, every minute counts. So if you have a patient sitting in a trolley that needs admitted to a ward, every minute that the patient in the ward's not gone, but was medically fit to go, is really wasted time for that patient who needs to be in the right setting. And they also, it's our duty to try to smooth their discharge as quickly as possible. Part of that might be to obtain a domiciliary home care package. And in our trust, we are responsible for the purchase of that. It's not the council, you know, it's not anyone but us, not the local authority. And I have a team who work miles from the hospital who broker those packages of care. So if I'm the social worker on a ward and for a ward, and I have identified that patient A needs 3 calls a day, and the first call has to be at 8 in the morning, the provider of the package has said, I could do that, but I can't get there to 8:30. That's a no in the old world. But using Vocera, this is a whole quality improvement project I did. Actually, if you rang the social worker and the social worker uses Vocera, and you can ring the Vocera badge, you don't have to ring on a mobile or in a hotspot, not get them, or a black spot, or they don't have the phone with them, or it's on silent in their pocket. You can actually get them. They can speak to you, can divert that to a phone if they want a private call with you. You can use it as a private phone if you wish. And they have a communication and can say, actually, yes, we can tolerate the half-hour change, or we can tolerate 2 calls. The family are prepared to take the 3rd tonight just to get their family member home and out of the hospital. And all of that has smooth flow. We can see who's using their Vocera system and who's not. So if they say it's not working for me, and I go, well, you didn't log on for a fortnight, it's not going to work. So, you can hold people to account in the most supportive way, because maybe they're scared of it. Maybe they don't know how to use it. There may be more education they need. Yeah.
I've forgotten about all the benefits of it during COVID. I tried to wipe that bit of my life away.
I think a lot of us have, Matt.
I think one of the big advantages as well was that your on-call teams, like infection control, was so important during that period. And during the day, you could just ask the badge to put you through to the infection control on call, and they put it through to the person that's in the trust on the badge, who's in a ward setting or in the canteen or wherever they happen to be, before they close the canteen, that is. But at night or out of hours, that call gets transferred to their mobile phone. So they'll be at home in wherever, and they will be able to receive the call. But the nurse on the ward doesn't have to change what they ask for. They still just say, call infection control on call, be it at 2 o'clock in the morning, be it at 2 in the afternoon. And that whole process of having that ease of communication, and that taking out those steps of having to think, well, what time is it? Are we in on-call hours? Are we on this, blah, blah, blah. It takes all of that away and becomes so much easier as a result.
Thank you. It's really interesting to hear about all the benefits. The 80% stat that you see is unbelievable. I wanted to ask a question about, we've looked at all the benefits, about the challenges and maybe unexpected challenges. And Kate has also dropped a message in the chat, specifically for Matthew, but I think you can both answer. In your first presentation, you spoke about the challenges that arose during the rollout of the new tech. How did your team build a culture where they could identify where things aren't working as intended and feel safe to discuss these challenges and iterate the pilot as necessary? In some sense, that's about communication as well.
Yeah, Helen, do you want to take this, or shall I just start?
I can start. Doesn't matter. I was actually going to take it out slightly. The Royal College of Physicians published a document, and it was about how to improve teams in healthcare, and they linked it back very much to communication. They said there was 4 themes of barriers that you have to overcome, and one is interpersonal communication, how people communicate to each other. We it's not a mistake, it's called hospitality, hospitals. You want to be hospitable to each other while you do your work. But fear of failure is the second one, and people can be afraid of change, any change. I experienced it as I went live with Encompass Epic. It's also change in how you actually practice, new protocols. You can be afraid that you'll not get it right. And also people were afraid. I remember in 2009, people going, what is that? It's like Star Trek. And I was going, let's give it a go, because we've got it. And as long as you go alongside people and you listen, you can unlock. And human factors like stress and fatigue at work help make things worse. So if people see a win, they usually will go for it. And even the very fatigue of walking up and down a ward constantly from a single room to a phone exhausts. And we had learnt that from going to Tunbridge Wells to visit a hospital over there that was all single rooms, because our Ulster Hospital site is 100% single rooms in its new build. And we could not fathom, as the clinical team designing that, how were our staff, because we weren't getting more staff, the same number of beds. So the commissioner was saying you've got the same staff. How are we going to ever do it? You know, they're going to walk miles. So this cuts down on physical labour. And the final one is team instability. And it seems to attract people. When you see digital, people expect digital in the 21st century, and it's up to us to try to make it work for them in the healthcare system. That would be what I would say about getting around the challenge. It's a culture of can do, and make your job as good as you can be. Because if you were the patient in the bed, you'd want it.
Yeah.
Matt?
Yeah, I mean, in answer everything that Helen's just said, completely agree. I mean, I think whenever I've been on any sort of improvement pathway, be it digital or otherwise, I'm very much just that, you know, the journey is being taken by everybody together. You've got a team of people within recovery, you've got some people within QI, you've got myself involved as well as the patients, as well as and it's about having those very open, honest conversations and setting the scene so that a member of staff, if they've got the slightest bit of anxiety about it, they feel able to verbalize that. You know, they may be the most junior member within the banding structure within the team, but it makes no difference when you come to having an idea of how this can be improved, or an anxiety around its use, is how do you get that across, and having that really open, really transparent working group incorporating everybody, regardless of the of what you're putting in, is very important.
Clinically led, Matt.
Clinically led.
There's one message.
Very aware we've only got 2 minutes left, but a question here from John Todd from University Hospital of Sussex. He's asking about, this is presumably single site based. How would it work across 7 hospital sites, and being able to differentiate between the systems and the analytics required for that?
No problem. My team in the Down Hospital can communicate with the team in the Ulster Hospital. We can actually communicate with the Belfast Trust's staff that are on it. So this cuts across. This is it's like a telephone system. It's hard to describe, and I'm not a tech savvy wizard, but I know it works, and it works across sites, and it works from community settings into hospital settings. So that domiciliary brokerage team are not an acute setting. They would go mad if I said that they were. And they work in a location in a local town, and they communicate into the acute setting using the Vocera system, because you can dial it like you're dialing a phone extension.
Yeah. And we are a multi-site area. We've only got a smaller site, which is only a day case, or not even day case, it's an outpatient and radiology centre in the centre of London. But on the Vocera system, we can have communication between the two. We don't particularly use it in Bolsover because we don't need to. But on occasions where we've had problems with the phone signal, we've put Vocera into play, and we've been able to use it seamlessly.
Brilliant. Well, that takes us to the end of the call and the end of the webinar. And I just would like to thank Helen and Matt again. Thank you so much for your time today and presenting to us and our network. As I said at the beginning, this will be recorded and published online, which you can access through our Safety for All website. So thank you, Matt, and thank you, Helen, and have a nice afternoon, everyone.
Thank you.
Thank you very much, Josh, for the opportunity. Thanks, Matt.
Thank you. Thank you. Bye.